to move wherever we're doing our sessions from. But anyway, I can start. So my name's Dee, go by Deepshika as well. And then we've got Alex. We're both F1s. We're both SFP doctors in the Northwest as well. We joined MedTic as a national teaching committee. We've been doing a PSA series earlier in the year, I think in January. Then we did a finals series, which was a 20 session long series. Some of you might have come to that before you start your finals this year. And now we're doing F1 series, which is just a two episode thing. Today is going to be going through like important on call things, how to do S bars. I'm sure you've gone through some of those before in med school, but we're just going to refresh it with some context, some common examples that we get in hospital. We're going to go through death verification, and which is different from death certification. I know some of you put that in your feedback that that's what you'd like to go through, but death verification is what a lot of you will be asked to do sometimes on your on-call shifts. And death certification will only be for people who have been looking after those patients.
Okay, so sorry about the delayed start, but welcome to our first session in F1 Survival Series. So we've been through some of the learning objectives, so I'll do the first three, and then I'll hand over for the second three. So this sort of is going to need a little bit of interaction, just because it sort of will help with the flow of the session. So first thing we're going to cover is answering the bleep. So this is a very realistic situation. So you're the on-call FY1 covering medicine. It's 8:45 p.m. You receive a bleep from a nurse. The nurse says, "Hi doctor, I'm calling about Mr. Smith in Bay 3. He's not looking right, a bit drowsy and clammy. Can you come and review him?" So can people put in the chat just sort of their thoughts, what their first question might be, how worried you are, just some thoughts and what you might say to the nurse in this situation when replying to the bleep.
So we've got someone saying, "What's his news?"
Yeah, so that would be a yeah, it's a great first question, and I'll come on to the point of the fact that sort of vitals and the news score are sort of essential and should be your go-to when receiving a bleep. Any other thoughts? Okay, so we go on to the next one. So just sort of to get the brain going with these answering the bleeps, then we'll go through sort of an example of sort of like how you would respond to one. So so you're answering this bleep, so you're the on-call FY1 covering surgery. It's 3:15 a.m. You receive a bleep from the nurse. "Hi doctor, this is Nurse John on S4. Mr. Patel in bed 4 is having chest pain. Can you come and review?"
So we've got, I don't know if this was for the last question.
So,
but we've got things like what's in hospital for, when does it start, when they do an ECG whilst you make your way there.
yeah, so so I'm just trying to get the chat up on my phone because I don't think I can do both at the same time. But yeah, they're both very very good first questions, especially asking for the ECG to be done. It comes under sort of the putting a plan in place and delegating time sensitive tasks that should be done before you actually go and assess the patient. So move on to the next one.
really, really bad. And
What was that? Sorry.
Hi, sorry. I'm having difficulties with my connection. Is this session being recorded and will it be uploaded on your YouTube?
Yeah, yeah, it's being recorded. So sorry, I think we're having some technical issues with sort of so
Okay,
but yeah, of course
thank
it'll
you.
be recorded.
So someone's just written things like, how is the patient looking? Do they have signs of shock? Um, yeah.
Yeah, so I think um yeah, they're really good points to start on in terms of your general assessment of the patient's current situation. So asking about other signs and symptoms they might be experiencing. Um, okay, so if we go on to the next slide. So this is sort of a structure to how to answer the bleep. So assume everyone's sort of heard of the S-bar model in terms of sort of giving a handover, but it's also a really important tool to use when taking a handover and structuring your questions that you're going to be asking, especially when you are taking a handover from someone who might not be particularly well versed in giving handovers, so not sort of knowing what information is important to mention. Um, so when you're asking about the situation, um, you might have been told that they have some chest pain. Ask a bit more about that chest pain in terms of thinking about the questions you're going to ask to the person you're asking. So a nurse might have sort of limited sort of like experience in taking a history from someone with chest pain. So you're not going to ask specific questions like, is it pleuric in nature? You might focus more on the fact that, oh, okay, so is it sort of like when did it come on? Have they had it before? Those sort of questions, and then think about that symptom and your differentials, and ask about associated symptoms that they might be having. So they might sort of say palpitations, increase oxygen requirements, and then move on to the background. So ask about why they're in hospital, any recent procedures, such as like obviously on a surgical ward. If you think if the patient's drowsy, ask do they have diabetes. And then when you come on to the assessment, I think someone mentioned it earlier, but the main thing to speak about is their new score and their observations. So, what's changed in their observations? What are they scoring for? What's their baseline? And that's key in your prioritization and understanding how critically unwell the patient might be, and how quickly you're going to respond to assess the patient. And then ask about anything else in the assessment that you think is sort of relevant, so such as the BM, such as the ECG. Ask if bloods have been recently taken. Ask if any imaging has been done, and that will feed into sort of your recommendations, where you'd think about sort of with your plan mentioning sort of asking the nursing staff to do certain tasks that are time sensitive. So when you are making your way over there, or if you have to do something that takes more priority, so before you get there, you might ask for bloods to be taken, an ECG to be done, ask for a chest X-ray to be arranged. And then the other things which are really important in your recommendation, which is essentially putting your plan in place, is given your estimated sort of time that you will assess the patient, and saying, well, I think this patient is relatively stable. I have a more unwell patient to review. I'll be there in an hour, and that will sort of trigger whoever's sort of bleeped you in the first place to potentially respond, being like, well, I think they've actually dropped off. I think they're more unstable than that. I think they need a review quicker, or they might agree with you. So one of the number one rules is unless it's an emergency, don't go in blind when you're reviewing a patient. There's nothing worse than sort of rushing in to do your A to E and you have no idea sort of the background of the patient or what investigations they've had. Um, so unless it is a real emergency, take your time to look through the notes, and try and understand sort of what what might be going on with the patient. Have they been reviewed for something similar before? Because quite often, if you look back through previous sort of on-call notes, an FY1 might have reviewed the patient for a very similar thing a few nights ago. So you can learn a lot about the patient before going in doing your A to E. Okay, so we're now talking about handing over in the sense of you providing the handover, and this can be in a situation where you're speaking, you're sort of worried about a patient, you want to escalate to a senior, how to sort of structure your handover in a way that is concise and clear and gets all the important information across. And this is really important, to take your time to sort of almost plan out what you're going to say, maybe even write it down. Especially when you're speaking to a senior about a patient you're worried about, you want to almost sell the patient to the person you're speaking to. So you don't want to be repeating yourself. You don't want to sound like you're not sure about certain things or you're getting things wrong. And you don't want to overload the person you're handing over to with too much information that might not necessarily be important or relevant. And it can be difficult for the person receiving the handover to sort of put together a picture of what's going on. So when you're thinking about the SPAR, concisely say who you are, who you're speaking about, and what the immediate problem is, and therefore what you think is going on. And we'll come on to an example after this of sort of a way you can do that. Then when you're talking about the background, so briefly mention why they're in hospital. Don't go through like an extensive list of sort of medical sort of problems that they have. Be concise about what's going on, similar with their past medical history and potentially their medications that you might want to think about. What's important in the background as well is their resuscitation status. Quite often, when you finish a handover, the number one question that your senior will ask you as well, what's their ceiling of care? Are we going to do anything further than ward-based care? So that's always a good one to throw in there. In terms of your assessment, this is really important that you're sort of clear and structured in how you go about relaying this information. So start with your A to E assessment, and included in that is sort of investigation findings. So if they've had a recent chest X-ray, what did that show? And you can talk about that in B. Any sort of like recent bloods that they've had in E, BM, any other vitals, and any other imaging or investigations. And you should be able to speak about a new score in there as well, and their observations. You can either feed the observations in at each part of the A to E, or you can have sort of a separate part to your assessment. You might even start with it, talking about what their new score is and what they're scoring for on certain parts of their vitals. In terms of your examination, there are obviously parts you don't want to sort of say everything that might not actually be relevant to sort of the initial presentation, but you might have sort of examined. So you might have made sure their abdomen is soft and non-tender, but it might not, it might just be assumed that that's the sort of the situation, especially if the patient has something sort of like drowsiness and like reduced consciousness is not sort of an important negative that you might raise. So you don't need to say everything in your A to E. Think about the important positive findings and important negative findings as well. And then in your recommendation, really important to say what you've done and what you basically structure it and what you've done and what you like someone else to do. So I'd like you to come and review this patient urgently. This is what I've done. This is what I'm planning on doing. So I might take these further bloods. I might organise this imaging. I might go and do an ABG. Can you come and review the patient urgently? Is there anything else you'd want me to do? That's a really good way of sort of leading into them sort of adding on to your plan and giving further recommendations. So I don't know if anyone's going to be sort of brave enough to step up to this. I've sort of given a bit of like a story here of a patient. sort of essentially on an orthopedic ward, and you're the FY1 overnight who's just reviewed this patient. I hope some of you would be worried about this patient and that you'd want to escalate it to a senior. So I wonder if anyone would try and give a S-bar for this case.
I'd encourage everyone to have a go if you can. You're going to have to do it in about a month's time.
Yeah, if you think it's scary doing it in front of a few of your sort of your mates, then try doing it at 3 a.m. in front of the med reg.
And the med reg is nicer than they're made out to be, but it's good to practice now if you can.
Yeah.
So Alex, I've been on anesthetics and IT for the last 3 months, right?
Mm-hmm.
I feel like I've gone back a bit. Shall I have a go? I might
Yeah, I was gonna say if no one was gonna suggest it, would you kindly
have a go because
have a go? Oh,
I might
thank you.
to imitate what I was like at the beginning of F1 at this point in my life. So just reading that a little bit. Okay. Okay. So so you've got hi, my name's Dee. I'm one of the F1 doctors. Calling about 72-year-old Barry, who's currently on D1. He's on a particular ward. He's day one post-op enough. He's got clinical signs and symptoms in keeping with what I think is an ACS happening. He's got ST elevation on ECG, he's tachycardic, hypertensive, tachypneic, and he's saturating. He's slightly hypoxic, 94% on 4 litres oxygen. Bit of background, as I said, so he's got no significant medical history, not on any regular medications, and currently full resus and escalation, other than the fact that he's day one post neck of femur fracture repair. I've started some oxygen, I've gained some IV access, I've taken some TROPS, so we're waiting for the results of those. And I'm just really, really concerned about a STEMI essentially. Is there anything else that you could advise right now to further along the ACS management? And anyone else you'd want me to contact? Yeah.
Yeah. That was great. I think yeah, you covered everything, and so I've essentially sort of written sort of a sort of how I like going through the S bar, which I think you did that well. So yeah, obviously introducing yourself, saying who the patient is and where they are, and then sort of talking about the current situation of the patient, so what signs and symptoms they have. So getting in there, that sort of the main thing is that they've got this new central chest pain, they're hypertensive, and they've got ST elevation on ECG, and sort of those 3 things would sort of lead you to think that you'd be very worried about an ACS. I think you sort of mentioned some of the other sort of findings in terms of like the observations, and the fact that like he's tachypneic and tachycardic and sort of has an increased oxygen requirement are like really important vitals. And I think it sort of doesn't matter if you put them in the assessment or the situation. It still it adds to the overall sort of selling the patient to the med reg. And then it was really good to just get in there in the situation. This is what I think is going on. I think they're having ACS and I'm concerned about this. So now you've got the attention of the med reg, then sort of moving into the background, sort of not going over the top, but saying, yeah, they've had a uneventful NOF that they were recovering well from, no past medical histories. I think you sort of got in there for full resuscitation escalation. And then the assessment, so sort of going through your A to E, so like, just on at the end of the bed, so sort of describing sort of the clammy, short of breath, and then going through the vitals. So sort of you did that in situation, but again, it's important to sort of like really like hit home that, especially the fact that they're hypertensive, you'd be really worried about this patient. And then sort of speaking a little bit about like the rest of the A to E in the sense of like key negative findings, such as like their chest is clear, heart sounds are normal, it's a regular rhythm, calves are soft, because you'd obviously be thinking about differentials such as a PE here. And then you'd look at the surgical site, because again, the patient might just be bleeding out, and that might be a cause of their hypotension. So it'd be important just to make sure that they're not hemorrhaging. And then the fact that the ECG is indicative of a STEMI. So again, saying in your recommendation, this is what I'm worried about, I want you to review emergently, saying what you've done and what you will do. So you've done the basic things, oxygen, IV. So I would have thought you'd given this patient some analgesia as well. What bloods you've taken. So you probably take your sort of like routine bloods in this situation, plus your sort of troponin as well. And then sort of offer anything else, offer your assistance in any other way, such as who else you could contact, which you mentioned there, and maybe other investigations that you think might be relevant, such as chest X-ray, and potentially starting aspirin as well. So you can see sort of like if you take the time to think about your sort of the way you're going to hand a patient over, it sort of leads to this quite nice narrative coming out, which is structured, and it allows the person receiving the handover to really understand your thought process, and sort of have a clear understanding of what's going on, what's been done, and what is needed from them, essentially. So just sort of put in the importance of closed loop communication in handing over to anyone, but sort of a lot of the time when you're sort of putting a plan in place, it's important to mention it to nursing staff. So even if it's something as simple as like an ECG, or changing a wristband for a patient because they actually have an allergy, something as simple as that, but actually making sure that the right person is told about it and they sort of respond by saying, yes, okay, I will do that. And you sort of, that closes the loop, and you can also say to them, can you let me know when that job's been done? Otherwise sort of things get lost, and say you've got a long list, you might say, okay, can you do that ECG? But if they don't tell you they've done it, then you might never get around to actually reviewing it. Okay, so we're moving on to just confirming the death, which is again a very popular on-call job to be given. So it's the first one or two you'll do are really scary, and you'll sort of make it into a bigger deal than it is. Obviously, it's like quite overwhelming seeing someone dead, or newly dead especially, and sort of you might have seen them alive, and it can sort of be a bit emotional. So sort of give yourself a bit of time, sort of like, don't go rushing into it. Maybe make sure you think you're going to have a bit of time afterwards to just sort of sit, sort of not rush into the next job. And it's important to do it right. Not in the sense of like making sure obviously you do the job right and confirming that they are actually dead, but also sort of like for family and relatives that might be in the room, to sort of give them the dignity they deserve. So the first thing is obviously make sure they actually have a DNAR in place, or sort of the decision to not carry on with any active treatment has been made. If it's the end of a cardiac arrest, then just wait 5 minutes. I think it's sort of just protocol to wait that long rather than just confirming it right then and there. And be so sort of not just be prepared, but know if there are relatives that are going to be in the room. because, you know, they want to know what's happening, so you'll have to explain. You might want to sort of read about sort of what's happened to lead up to their death, because if it's in the middle of the night and it's a patient you don't know, then you won't necessarily know why they've died. But if the relative's in the room, they will be asking questions. So you don't want to sort of not be able to give them answers, and sort of have a bit of an understanding about what's going to happen next, for processing the body, at sort of like going to the morgue and that sort of process and leaving the ward. The nurses like know that process quite well, so just speak to them before going in. And then actually your job is to assess three things for more than 5 minutes. So any signs of breathing, so you just stood at the end of the bed, do they look like they're breathing? Is their chest rising? Look at their lips. So then you're going to listen to the chest, so listen to the all the sort of lung feels. Are there any breathing sounds? And then within that, you can sort of try and listen to the heart, see if there's any heart sounds. So listen over the area of the heart. Feel for central pulse. I always do central pulse, radial pulse as well. Just to sort of be double sure and try and do both sides as well. Look in the pupils, so get a torch. Are they fixed and dilated? Corneal reflex, so get sort of a piece of cotton wool and just gently touch the eye with it, see if there's any reflex, sort of like shutting of the eyelids. And then you can do a trapezius squeeze or supraorbital pressure. And it's important, especially if the family's in the room, to sort of speak through each step of this, so that people aren't sort of like confused while you're looking in the eyes. Or, you know, even things like trapezius squeeze, don't make it overly obvious. Or if, you know, you feel like you have to do it and they're going to see, just explain why you're doing it. And then your documentation is key. So the patient only died when you verified that they died. So essentially your job is to assess for any signs of life, and if you as a doctor can't sort of identify any signs of life, then you have confirmed that they've died. Sorry, you verified that they've died. Important in sort of understanding, I think we spoke about it earlier, sort of the difference between certifying death and verifying death. So verifying is just confirming there's no signs of life, and that's your job. But certifying death comes from the team actually looking after the patient. So at 3 a.m. you don't need to certify any deaths. All you need to do is verify they've died, and then the team looking after that patient can formally put in, sort of document what the actual causes of death are, and that's when sort of like you'd consider coroner's referral. But in the middle of the night, that's not your job. And if you're at all concerned, say you were part of that parent team and you were asked about these sort of things in the daytime, then you, of course, if you're not fully aware, then you'd have to speak to your senior about what you want to put on the medical certificate. So yeah, and then the other thing is just make sure you inform nurses and the relatives that the death has been verified. Nurses don't tend to like to take even like oxygen masks off until death's been verified, or cannulas can come out, and sort of like blood pressure cuffs can come off. So again, that's really important for sort of dignity of the body at that point. Okay, so I'll move on to next part of the talk.
Okay. Hi, Alex. Are you okay to go through skip through the slides?
Yeah, of course.
Right, okay. So the next, just the last three topics. So again, a bit of interaction would be useful, because you'll encounter these situations. So the next scenario is you're an F1 on a surgical ward. You've got a 76-year-old man. I don't know why all the examples are elderly men. I'm sorry. He's day 2 post-op from a hemicolectomy. He's more drowsy than earlier. He's tachycardic, hypotensive. His resp's 24. He's got a temperature. It's 95% on room air. He hasn't passed any urine since this morning. You're quite worried, rightly so, I would hope so. So you've got 5 options there. What is the most appropriate next step? You can put it in the chat, or you can say it. And if you, whichever way, just explain why. In many ways, quite a lot of those answers are all correct. There's one that's definitely wrong, but the others can all feel correct. But one is the most appropriate next step. Okay, yeah. Yes. Presumptive sepsis, is it septic? Yeah. Okay, yeah, you're right. Escalate is a correct answer, which takes us on to the next topic of appropriate escalation. So yeah, you'd escalate because of so they're in hypovolemic septic shock. Yeah. So you'd want to escalate first, and then whilst the reg comes, you might do the rest of those things. Okay, it would be completely inappropriate for you to just monitor this patient and recheck in 30 minutes. That would not be good. Right. So going on to the next slide. So, yep. So it's happening most likely because you've got an anastomotic leak from the surgery. Then they've got peritoneal or retroperitoneal fluid. So that's where they're losing blood, or you've got a collection, and the hypovolemic, and you've got end organ hyperperfusion, which is shown by the fact that they haven't passed in urine. Okay, and you've got the pyrexia, so you need to get your skates on with this one. Right, next slide, please. So a little bit of background about escalation and some teaching around it. So escalation is not a sign of failure. It's a vital safety netting thing, and even experienced clinicians escalate depending on if it's within their scope of practice or confidence level, or confidence level at that point in time. So the earlier you do it and the clearer you make it is a mark of a really good judgment call. If something feels wrong, you can use acronyms like STOP, so stop, assess, and escalate, and rely on your sort of instincts a little bit, because your F1s, you're not like a registrar level. You're not going to be expected to do what PassMed makes you do, which you've been doing during revision, which is just like going to the treatment. It's really good to know those things. Please don't lose those kind of skills, because a lot of F1 is about teaching you the stepwise mechanism, and in doing so, sometimes people forget that they do have all of this knowledge in their head. So you do need to have it, you need to retain it, but you sometimes just can't act on it all the time without confirming that that's the right thing to do at that point. Okay. So deciding when to escalate is also important. So I sometimes use an acronym called STOP, which is if you've got news that is above 5 in total, or 3 in one category, treatment's not working, or there's worsening condition, or you're over your competence or confidence level, or if you've got patient or family concerns, or you've got DNA CPR and ceilings of care are sometimes unclear, and that happens often. So these are just things to be aware of. There's some common pitfalls that people get into trouble with. So waiting too long, not having all the relevant info, not documenting the escalation, not using SBAR, so you have like a rambling storyline, people have lost interest, and not being assertive enough. So a bit about the documenting and escalation. So you need to try and document every escalation point. So you call your reg, and they're not contactable. You need to document that you tried to call and they were not contactable. Then you need to document when you tried to call them again. And at some point you should go, well, I'm not getting hold of anyone that I need to get a hold of, so I'm still stuck here with this patient in this problematic situation. What am I going to do? And the one thing, it's very daunting, but you need to be prepared and happy to escalate above the reg if you can't get hold of them. Okay. So you need to figure out the escalation pathway in that particular department or that ward. It might not always be reg and then consultant. It might be like JCF, then senior clinical fellow, CT, then reg, or whatever. So whichever way it is, you need to document each escalation point, what response or advice you got, what action they suggested, what you did with it, and then move on. Okay. And don't be afraid to contact the consultant. You won't medical legally, you won't be criticised for doing it that way, if that makes sense. interpersonally on a day-to-day basis, it might cause a little bit of friction until you get your bearings, but I would ignore that, frankly. Patient safety is at the end of the day the priority. And yeah, so preparation is also really key. If you don't know something, be honest and say that you're finding it hard. And as I said, document when and what was said. So next slide, please. So as I mentioned before, knowing who to escalate to is really important in your current environment. So it depends also, like when you get your departmental inductions, these are some of the questions that you should be asking. So they'll give you a lot of information in your induction about where things are, equipment wise, yeah. Guidelines that you need to know, documents that you need to be aware of, rota people that you need to be aware of. There's an absolute plethora of information that's just thrown at you. But these are some questions that you need to have at every rotation that you go to. What's the escalation pathway? Who's on shift with me? What are their skill sets? Okay, if there's anything unclear, just be a bit twigged on with that and ask. And if all else fails, there's always switchboard. So always, usually can get through to switchboard in any hospital by just going either 0000 or just 0 and ask for whoever you think you might need. And sometimes you go around the houses, but eventually, if you're persistent enough, you'll get to the right person. Okay. So with how to escalate, I think we've been through it, so I won't bore you with it. You're going to do an SBAR situation template. So you're going to say, you've got a 78-year-old 2-day post-op hypovolemic shock, the OBS and current findings, what you're going to do, what you've done so far. So you're going to have given them some fluid boluses, ensure they're catheterized. You're going to have some bloods, blood culture, septic screen, antipyretics. And the fact that you're probably going to need a CT scan. Sometimes with the MedReg or whoever you're going to escalate to, it's fine to give all the observations and stuff, but if you give your concise interpretation of what you think is going on, that grabs them better. Okay, and then if they ask you what the exact observations are, then you can. Okay, next slide, please. So yeah, just a bit of summary. Takes about golden rules: escalate early, use SBAR, be calm and clear, even when under pressure. Easier said than done. I'm aware of that. Document the conversation and the plan, and follow it up if you don't get a response. So, like I said, if you don't get a response with that one person, try them again. Unless patients you feel like they're going to crash right now, at which point you need to be calling up 2222. And then document each one. If you're finding sometimes documentation can be really, really onerous, just to log on. And then everything's got a timestamp, or if things are happening too quickly, just have a piece of paper and document as you go along with your handwriting. Okay, and you can transcribe it back up and keep a copy of that, as a photograph or something like that, in case it comes into question later, and say that you didn't just log on and make up this timeline. You were writing contemporaneously at the time. Okay, and importantly, know that you're not alone. Be confident. You're not alone in not knowing everything, if that makes sense. Okay. Yeah, next slide. So next scenario, you're an F1 on a busy medical ward. Don't know any medical ward that's not busy, but yeah. Busy medical ward, you receive 3 calls all at once. You've got from the nurse, asking you about all 3 things. So you've got a patient who's got a news of 7, they're tachy, hypertensive. Another person who needs all the discharge meds to be done because it's about 3:30 and the pharmacy shuts at 4. And so if you don't get it, that means that they're going to end up staying, and the bed manager is going to be knocking on that charge nurse's office, who's then going to bother you with it. And then patient C, who's asking for pain relief. What's the most appropriate order of action? So you've got 3 options. Well, you've got 3 different permutations, but you've got 3 choices there to swap around with. One, 3, 2. Yeah. I mean, I suppose I think the answer's kind of written in the phrasing there, isn't it? Yeah. So if you click again, Alex will come up with the next box. Yeah. So yeah, you're quite right. Patient 8, ill people first, then discharge summaries, then anything like non-urgent, even though people in pain obviously are urgent, but you'll soon realize that these kind of scenarios either come frustratingly exactly after ward round or just before you're about to leave work for some reason. I have no idea why. And that is the way to do it, especially if it's after ward round. You do the ill people first, then you do the discharge summaries and TTOs, and then you deal with any other like not miscellaneous, but like requesting scans that are non-urgent, or prescribing like potassium or analgesia. But when I say prescribing potassium, like if it's low, not just like dangerously low. Yeah. And you have to do this at every, so you could make like a 20-point job list, right? You've prioritized everything, and then you get 3 more, or you get 1 more. At each point that you get new information or a new task, you have to reprioritize your entire list. And it's really frustrating because you've already spent all of that lovely time doing it, but you've got to get into the habit, and that's what F1's about. You have to do the reprioritizing every time you get new information. And the reason you have to do it is because it enhances patient safety, it manages workload efficiently. You get with the more you practice, it reduces your stress and burnout, because you can't possibly do everything at the same time, and that ensures you get timely escalation and care. And it's also really useful for handover and shift transition. So if you've done all the really acute and important things first, even if you are having to hand over the last 10 jobs out of 20, it feels like you have to hand over half your things, right? But those first 10 could have just taken you forever to do, because those are difficult tasks. People taking shift from you might be visibly frustrated. You've got to try not to take it personally, because one day you will be that person. So you'll understand why you're getting maybe 10 jobs. And it's not everybody you'll find in your cohort is emotionally mature as you'd expect F1s to be. Everyone's got different backgrounds and things like that, and different thresholds. But it's important that if you practice patience with other people, eventually you'll get it back at some point. Okay. Next slide, please. So just a core summary about prioritization. Safety first, unstable patients, then stable ones. Make sure that you react to the time sensitivity of anything. So deteriorating patients, stat meds that need to be done, making sure that you use A/E assessments, delegate, so use your team effectively. You've got nurses, HCAs. Some HCAs can do bloods and cannulas, some nurses can do bloods and cannulas. You've got advanced nurse practitioners, you've got advanced care practitioners. Some of them can prescribe if they've done their prescribing qualifications. You've got physician associates that you'll be working with, so they can't prescribe, but they can request scans. They can do electronic referrals, and they can document. So use your team. Okay. A good thing that we came up with on our ward was after the ward round. So say we had like 25 patients and 3 or 4 junior doctors who did the ward round prep and then did the ward round with the consultant, and we were each allocated, say, like 4 patients each, okay, something like that. We would all individually have a job list for our 4 patients, but what we would do is we'd create a master job list on the board, like a physical whiteboard or a piece of paper, and we'd put everybody's job list on there, okay? And so for like the initial bit of the remainder of the shift, we would try and do our own patients' jobs, yeah, and get through as much as we can. And periodically, we'd ask if anybody else needed help with theirs, okay? Or at equally at like sort of 4 o'clock in the afternoon. So you're meant to finish at 5, I think, and at 5 you hand over patients to their night team or your acute care team. We'd, as a group, go through that massive job list and say what is remaining that needs to be done before 5, what needs to be handed over to the night team, and what can wait till we come back in the morning again. Okay, and that helps with like building team working, fostering like a really positive culture of helping each other, and it means that not everybody's overloaded, and it also ensures that everybody left on time. And that was one of one of the things I noticed that even though I was working in a gastroenterology ward, we all left on time, which was shocking when I told everyone, but we did. We got through all the jobs, even though we had lots and lots of jobs. Next, click, please. Yeah. So just I think we've covered that really, isn't it? Action analysis. These are just helpful acronyms that you can go through. So acutely well, critical interventions, tasks, non-urgent reviews, organise your tasks, and anything that can wait, essentially. And be mindful that sometimes you have phlebotomists in each hospital who come and do the bloods the next morning. They'll come around 7 to 7:30, which is much earlier than you'll start your shift. So you need to recognise the evening before you finish which patients might need bloods. You need to print them out, label them with the bed number, put them in the bloods folder, which sits on the ward desk, the nurse's desk, so the phlebotomist knows who to take blood from, which saves you a huge list of tasks the next day. Okay, next slide, please. So tip for managing the list, you can click the next thing as well. It's just got a summary here. So tip for managing the list, write everything down, keep a running list like I suggested. Have a rough idea in your brain of how long each task is going to take you. It'll take you longer when you first begin F1. You'll slowly get better at it because you'll know your hospital infrastructure system, who's the friendly radiologist, who isn't the friendly radiologist. Each ward or specialty has like their own pharmacist. Really good idea to keep on their good side and be on talking terms, or so you can call them and be like, really struggling with this TTO, I've prescribed this isn't working, what can I do? You'd be surprised at the plethora of technical issues you can have thinking you've prescribed something correctly, and you probably have, but the system's just not playing ball with you. Next. So we'll move on to, for the benefit of time, this is just a bit of summary on prioritization. We'll move on to the next slide. So a bit about arrest calls. So arrest calls, usually if you're on this refers usually to medicine on call. So if you're on a medicine rotation, you'll have long days, and you'll go to your acute medical take shift where you're taking over the night team, and you'll usually have a med reg, and there'll be some F1s, there'll be some F2s, you'll have some CTs or SHO grades or IMT grades rather, and before, so they do the handover, and then the night team goes, or the day team goes, depending on what shift you're doing, and then what they do is allocate roles for arrest calls. So you'll have who's airway trained, who wants to do A and B, who wants to do C and cannulas, who wants to do drugs, and then D&E, who wants to be the runner, who wants to operate the defib, and who wants to scribe. And you do usually like a run of long days or nights. So like I think it's like four days or 4 nights. And you, if you want, you can have a different role, so you get a flavour, right? Okay. And you'll become quite close with that team, because often when you do your on calls, because of the pattern of rota, you end up sometimes with the same people. So you need to decide all of these roles before you start your shift in case you get a call. There's no point, well, you can allocate it when you get there, but it's quite frayed, as it were, at the time when you get there. So if you click next, so you'll delegate all these critical roles, and you'll also delegate all the A to E roles. Okay. Next. So first on scene, if you happen to be first on scene, you're going to do your basic BLS, check the scene, shout for help, press the emergency buzzer. Nurse will come, you'll go get them to call 2222 through the switchboard and say that you've got a crash call on this ward, in this location in the hospital. The location and the ward is really important, much more than the patient, so that people know where to go. Okay, begin CPR. If you are the doctor, you might sometimes be the most senior person if you're first on scene. So begin CPR if they're unresponsive and pulseless. Ask them to fetch you the crash trolley. And this is happening after you've called 2222, so people are on their way, hopefully. Okay, and you're going to do your basic life support and consider your 4Hs and 4Ts as per ALS algorithms. And hopefully by that time, everybody from the Met Call team will have come and the Met team is usually, as I said, the med reg, the F1, the F2, and sometimes acute care, and sometimes you'll be on that Met team as well. Okay, so it pays to pay attention to what's happening on each side. The main thing is try and be calm. It's difficult. Communicate clearly and loudly, especially if you think that something's going on that you're not happy about. Even if you're the F1 day one, you think something's wrong, put your hand up, say it loudly. No one's hearing you. Make your way. Stand next to the med reg, who's usually the leader of the situation, and say it to them. Okay. So try and focus on structure, not chaos. Sometimes you're allocated a scribe. People won't be telling you, oh, I've put the adrenaline in at this time. You've got to like basically pay attention to the clock and what everyone's doing. So it might be useful in the first few times if there's enough of you to just have an observation role on the first crash call and make that obvious from before you get to the crash call. Say that to the med reg that on this occasion, can I be the spare, or if there's enough people, obviously. And then see what the scribe does or see what each person does and then learn from that. And you might be fine, but you know, depends. Yeah, next slide. Yeah, so the big bits, if you do happen to be scribe on call, capture the essentials, details of the ID, time of collapse from what the nurses say, when CPR was started, the rhythm that they were found in, drugs given, dose and time. Each time you got return of spontaneous circulation, you'd be surprised sometimes it happens multiple times and they go back into PA or BTVF. Ensure that everything's handed over verbally and in writing. After each arrest call, there's usually an IR1 to fill in. So your documentation of that crash call is what is used to go into the IR1, okay? And having an IR1 for this is not bad, by the way. It's very normal practice to have an IR1. An IR1 means like a day text or a significant event. Even if it's known in the notes that this patient was just really bad, doing really, really poorly, but they just happened to be for full resus and they had, they had an arrest, and then you had to go through this process of CPR. So yeah, and then liaise with the nurse in charge or clinical site manager to follow up on what's going to happen next. Afterwards, there'll usually be a debrief session with everyone who attended that arrest call, usually led by the med reg. They'll go through all the checks that are on top of the crash trolley. You know, like, do we feel that everybody was organised? Do we feel that we acted at inappropriate timing? Was there any equipment missing? What could have been done better? Did we have all the appropriate roles? And they will finally finish with, like, how is everyone feeling? Are you happy to go back to your shift? Do you need like an extra 20 minutes, 15 minutes? And the reason they ask that is that if you do need a little break, they need to know so that you can hand over your bleep that you're covering for that shift for that brief period. Okay, so you can have a proper break and then you go back and recollect that bleep. Okay, and so in summary, if you're part of the Met team, it's usually okay because you've got lots of people with you. If you happen to be on the ward alone and you've got an arrest that happens on your ward, be prepared to act sometimes before the senior or the Met team arrives. Just be structured A to E all the time. Okay, you'll get used to it by, I think, like month 2 or 3. It'll be reflexive memory. Okay, and then documentation as then everything in the NHS is really important. Right, next. I think that's the last slide. So we've covered quite a bit there. We've run over slightly, so thank you for staying with us. So if you could scan that would be great. That's our feedback link. We do rely on your feedback to make our next sessions better. If there's anything that you want covering next time, in addition to what's already on schedule, so next session is next Thursday, which is on how to make the most of F1. So things like portfolio, well-being, etc. If there's anything from today that you want to just ask a bit more about, just put it in to the feedback and we'll try and address it next time if we can. If you've got any other questions, me and Alex will stay on for a few more minutes. But otherwise, thanks for spending your very sunny July evening with us.
Yeah, thanks, guys. Sorry about the start as well. It's our first time we've done this over Teams rather than Medal, so it took a bit of sort of
Yeah.
getting used to. But I think we'll edit that for when we upload it.
Yeah.
Yeah. Thank you.